Good morning. Welcome to the Audit and Performance Committee of the Perth and Kinross Integration Joint Board, Monday the 13th of March 2023. I'd like to welcome some new faces today. I think Martin, we'd like to welcome Martin, who is taking over the post that was vacated by Donald for NHS Tayside. We also have, I think, I'm trying to look at the names, and apologies, I'm having to chair this online today. I tend to try and come into chambers, but apologies, I have to do it online today. So Maggie Bruce, I think, is it Maggie is from External Audit today? Maggie, welcome. Is there anyone else?
Chair. No, just myself, thank you.
Okay, thank you. Welcome to the meeting. We've also got a couple of new faces that I am not sure of. Is it worth going round the attendance and introducing ourselves? Right, I'll just start anyways. I'm Beth Hamilton and I'm Chair of the Audit and Performance, and I'm a non-exec director with NHS Tayside as well as Perth and Kinross IGB. Adam, on my list, could you go first, please?
Yeah, thanks, Chair. I'm Adam Taylor from the Committee Services Department at the Council.
Okay, and then Audrey Brown.
Audrey's just one of the meeting producers, Beth, so we'll just skip past Audrey.
Poor Audrey. Chris Jolly.
Good morning, Chris Jolly. I'm a Service Manager for Business Planning and Performance within the Health and Social Care Partnership.
Thank you, Chris. And another Chris Lamont.
Morning, everybody. I'm Chris Lamont and I'm Senior Service Manager for Mental Health.
I've got on here Councillor David. David.
Hello, I'm David Illingworth, Councillor and I'm a voting member of the IJB. Thank you.
And I've got Sheila Cole, Councillor Sheila.
Morning, Beth. It's McCole, not Cole.
Oh, sorry.
Morning. I'm a councillor in Perth and Kinross Council. I'm also a voting member on the IGB and on the Tayside NHS board.
Thank you, Sheila. Dave Henderson.
Morning, I'm Dave Henderson. I'm the Scottish Care Independent Sector Lead for this area, and it was previously Lynn Blair that was in post.
Welcome, Dave. Hamish Dougal.
I think we've got apologies from Hamish this morning, Beth.
No, Hamish is there. I can see him.
All right, sorry. Can't see
Good morning. Sorry, my microphone keeps muting itself. Hi, I'm Dr. Hamish Dougal. I'm the Clinical Director for the Partnership.
Thank you. Jackie Clark.
Good morning, I'm Jackie Clark. I'm the Chief Internal Auditor for the Integration Joint Board, as well as for Perth and Kinross Council.
Okay, thank you. Jackie Pepper.
Good morning, it's Jackie Pepper, Chief Officer for the IGB and Health and Social Care Partnership in Perth and Kinross. Thanks.
Thank you. Lindsay Hunter.
Hi everyone, my name's Lindsay Hunter. I was Lindsay Glover, so that's possibly where you're getting muddled up. So I'm a staff side representative for NHS Tayside, but I'm also the lead partnership rep for Perth and Kinross Health and Social Care Partnership, and I'm a part of the IGB as well.
Thank you, welcome. I think Magda, is that somebody that's an organiser as well? So
yeah.
Okay, Maggie Bruce, we've already welcomed you, Maggie. Thank you. Mark Grant.
Good morning, I'm Mark Grant. I'm the Interim Finance Manager for the Health and Social Care Partnership in Perth and Kinross.
Thank you. Martin Black.
Morning, Beth. I'm Martin Black. I'm a non-executive director on NHS Tayside, and also I've just came onto this IGB committee.
Thank you. Zoe Robertson.
Hello, I'm Interim Head of Adult Social Work and Social Care and Service Manager for Commissioning and Policy.
Okay, now that's all I've got online. Could we have introductions from the meeting room that haven't been already mentioned?
Good morning, everyone. My name's Donna Mitchell and I'm the Interim Chief Finance Officer for the partnership.
Good morning, I'm Phil Gerrard. I'm the Governance and Risk Coordinator for Perth and Kinross Health and Social Care Partnership.
Good morning, Kenny Ogilvie, Interim Head of Service, Adult Social Work and Social Care Operations.
Beth, we've also got Sandy Watts online. I think you missed her in your list when you were going down.
Oh, Sandy, my apologies.
That's quite all right. Thank you, Beth. My name's Sandy Watts. I'm on the board of Independent Advocacy Perth and Kinross, and I'm the third sector rep on the IJB. Thank you.
Thank you. Okay, I think that's everybody then. Can I particularly welcome Donna Mitchell, who's our now our interim Chief Finance Officer. Welcome, Donna. The other thing I have to say at the beginning is I have to leave the meeting at 11 o'clock. If the meeting is not finished, which I'm hoping it will be, because I think we've got nothing contentious and it's quite a decent agenda. Martin's agreed just to finish up the meeting for me in case we haven't finished. So thank you, Martin, for agreeing to do that for me. Right, so that's all the welcomes and the information. Have we any apologies?
Yeah, just one apology this morning from Bernie Campbell.
Thank you. Right, I'll move on to declarations of interest, and it's just to remind you that of your obligation to declare any financial or non-financial interest which you may have in any item in this agenda in accordance with the Perth and Kinross Integration Joint Board of Conduct. Any declarations of interest, please? Nope. Okay, can I ask, would it be possible to take this slide down so I can see more of the people online? If that's possible. Right, I'll move on to minutes of the previous meeting. So the last minutes were the meeting of the Audit and Performance Committee of the Perth and Kinross Integration Joint Board of the 22nd of November, and they're here for approval. Can I ask firstly, are there any points for correction or further discussion? Nope. Okay, can I have a proposer then, please?
Happy to propose.
Thank you. Thank you, David. And a seconder, please.
Okay.
Any seconder, Sheila? You were there, would you, babe?
Yes, I'm happy to second.
Thanks, Sheila. Okay. Next action points update. Who's going to go through this? Anybody want to take the action points update? I could go through them.
I'm happy to.
Right,
I'm happy
okay,
to.
Jackie, thank you.
Sorry, I was busy typing saying yes and didn't get it off, and I've realised I've made a mistake in my typing as well.
Okay.
Yeah, it was just to say that the risk workshop and the risk appetite session has been scheduled for this week, so that will take place on the 15th of March. It has taken a wee bit longer to arrange that particular session because the budget development has taken a priority, but that's now in place, and you should have had material issued already in order to prepare for that. So that's reference 50.
Okay, thank you.
Reference.
I think.
Sorry.
Yeah, I was just going to reinforce that we've all had the information to complete to send back to Phil today is the deadline to allow us to do that on Wednesday. So it's just to encourage everybody who hasn't done it yet to make sure you get that done before Wednesday. Thank you. Sorry, Jackie, if you want to move on.
Well, that's good. Thanks for the reminder. Then section 51, reference 51, we had been seeking a development session on clinical care governance as a follow-up to previous sessions, but it also takes cognizance of the refreshed membership and changing membership of the Audit and Performance Committee. So we're scheduling that for the 5th of May now.
Great stuff.
And then 52, that's now complete. We've received assurance from the Dundee IJB in relation to the clinical governance arrangements, and Dundee's IJB annual accounts were considered at their Audit and Performance Committee on the 23rd of November, so that's now been circulated to members.
Great stuff. Thank you, Jackie. That takes us on then to any matters arising that we want to cover before we move on in the agenda. Nope. Okay, well, moving on to performance. The first item in the performance is the 22-23 financial position. Donna, go for it.
Thank you, Chair. Good morning again, everyone. So this report provides the committee with an updated financial position for 22-23. This has been based on the actual expenditure for the first 9 months of this year and projections to the end of the financial year. The overall position is an underspend of 2.7 million, which is a considerable movement from the position last reported to the committee in November. The main reasons for both the movement and the underspends are detailed obviously within the report, but the movement mainly relates to a couple of areas. So firstly, the local government pay settlement funding. The previous reporting quite rightly reflected that there was a lot of uncertainty over whether this funding would be provided and if it would be provided at what level. Therefore, as I think everybody's aware, we now have confirmation and pass-through of the funding, which improves our financial position by just over 900,000 this financial year. The other material variances and movements from the last report relate in the main to staffing underspends. This has been caused partly by uncertainty over funding and therefore timing of investment going to within our budgets. And this, together with challenges in recruitment, have meant we have a number of unplanned underspends in areas right across health and social care, and these are also detailed in the report. The report also provides an update on the reserves position of the IJB, and this includes an update on the COVID-19 reserve. And also the report just confirms that as per the integration scheme, should the projected underspend be realised at the amount we're forecasting, this will be carried forward in a general reserve for 23-24, and it will be considered as part of our 23-24 budget. I'm happy to take any questions. I was keen to keep my summarising brief so that we could have enough time for questions. So if anybody has any, thank you.
Thank you for that, Donna, and thank you for the report. Any questions initially for Donna? Martin.
Sorry about that. I couldn't find. I've lost the wee thing that you put your arrow up and everything. In the underspend, and quite a significant underspend, and I know there are recruitment challenges, but is there any initiative about one, how we address that, or two, how we could develop a programme or a project where we could upskill staff to fill vacancies?
Thank you, Martin.
Beth, it might be worth inviting either Kenny or Jackie in. Kenny, do you want to come in?
I was going to say that. Kenny, do you want to give an update on that operational issue?
Yeah, certainly. I mean, we've got our workforce plan, obviously, which was signed off a few months ago at the IJB, and we are bringing an update on the implementation of that plan to the next IJB. And yes is the short answer. For example, in social care, we've just recently had a big recruitment drive, and we had over 80 applicants for vacancies in our internal heart service, which is pretty much unheard of. And at the end of last week, we'd actually recruited 20 people with interviews ongoing. So, there's a lot of good progress there, and we've had improved response to applications for social care vacancies across the partnership. There's a number of recruitment drives going on as well in EHPs and nursing. I don't know if Chris wants to come in on the nursing side of it. And in terms of developing our own staff, again, across the partnership, for example, I think it's 5 people we've currently got paraprofessionals on the social work side training for the professional social work qualification. We have got in psychiatry of old age, associate workers, and that's people sort of kind of in between a sort of healthcare assistant and a qualified nurse. It's not quite to the level of a qualified nurse, but it's training folk up to work at the maximum of their licence, and then making it easier for them to make the next step to become a qualified nurse. And again, we're looking at advanced nurse practitioners as well, which we'll speak about in the workforce plan updates. So in short, there's a range of initiatives across the partnership and across the professional areas.
Thank you.
Thank you for that. Chris, you've come up on screen. Do you want to come in?
Yeah, Kenny's actually stolen my thunder, Chair. So yeah, I mean, he's already touched on the advanced nurse practitioners, which we're currently recruiting trainee practitioners into the service, so that we're building out a future workforce. But we're also looking to recruit already experienced advanced nurse practitioners from other health board areas to try and make the roles and the jobs more appealing and more attractive. Kenny's also touched on the associate practitioner role, which we're beginning to roll out at Band 4 level as well across several different areas. And there is also, specifically around mental health, there is a meeting taking place this week with myself and some senior managers and the Associate Medical Director to look at a slightly alternative model within our community mental health services. Excuse me, I've got a sore throat this morning, just because of the current ongoing issue that we have on a national basis regarding consultant psychiatrists.
Okay, thank you for that, Chris. Martin, are you happy with that?
Yeah, happy with that. I'm glad to see
Thanks,
that
Martin.
these initiatives are happening.
Thank you. I'll go on to Councillor David Illingworth.
Okay, thank you. You mentioned that the Scottish Government are clawing back reserves. Why are they able to do that, given that we have a red on the risk register for financial stability?
The Scottish Government, the main reclaim is in regard to the COVID-19 reserve, and as detailed in the report, the Scottish Government very particularly passed that funding across in order to fund COVID-19 related costs. And with the public health guidance being changed and the costs no longer being incurred or expected to be incurred, therefore the funding we were assured that we would have sufficient funding to cover any costs that we did have in the system for this financial year. And as detailed, that reassurance is there. We have sufficient funding, and if we have projections wrong in any way, there will be an opportunity to do a reconciliation exercise in April, so that we therefore don't have any financial risk ourselves. But that was the basis that the funding was to be reclaimed, as it was very specifically passed across for COVID-19 related costs, and they are being incurred in the wider system. Therefore, the funding was reclaimed in order to support them where the costs were.
Okay, David, are
Thank
you happy with that?
Yep.
Thank you. Dave Henderson, you've got a question?
Thank you. Donna, just wondering, is any of this money that's been carried forward to next year, is any
Dave, you've gone on mute. Something's happened. You've gone on mute.
Sorry. It was just a quick question for Donna. Donna, the money that's getting carried forward to 23-24, I know it might be a bit too early, but would any of that be available to the independent or third sector?
Thank you, Dave. So the funding that's been carried forward is a general reserve, so therefore it's not committed. However, it will form part of our budget setting. We have an update on Wednesday for the IGB members to go through the development session for our 23-24 budget, and it's for us to prioritise where our funding, where our budget funding goes. think, as you're aware, there's a financial risk around 23-24 should additional uplifts be required, which includes the third and independent sector, and this additional reserves that we have will allow us to support our budget. So apologies, in short, it'll depend on what we prioritise within the budget and how we're going to spend our funding.
Okay, thank you for that, Donna.
Thanks, Donna.
Thanks, Dave. Councillor Sheila McCall.
Thank you, Beth, and thank you for the report. It's very helpful. My question is on the main report and section 3.19 and 3.20 about general medical services, and that further discussion is required regarding lead partner and financial risk share agreement for primary care is required. I'm just wondering if we've got a date for that, when that's going to start, or if it's in progress. And if it is in progress, can we add it onto the actions list, please?
It may be something that Jackie wants to pick up because it has been discussed in regards to the lead partner arrangements.
Yeah.
Jackie, do you want to come in?
Yeah, happy to pick up on that in due course, yes. Well, I think in terms of the lead partner arrangements, it's something that we're working through at the moment, and it continues to evolve and adapt and improve as we move forward, but it really does require collaboration across the 3 IJBs and NHST side. But we're working that through.
Is there any, if I may, Beth, Chair, if I may, is there any, Jackie, is there any sort of timeline for these discussions?
No, but that's something that I can certainly come back to you on. The strategic leadership group for, which is now going to be called the executive leadership group for inpatient mental health services and patient learning disability services, is now meeting monthly, so it is picking up a pace, but there's a huge amount of work to do there.
This is really about the financial risk share arrangements for primary care. Is that all part of the inpatient service review?
No, but it's in terms of the arrangement that we have with the strategic leaders, we would be able to discuss it in that forum. But the primary focus at this point in time has been around inpatient mental health services.
Okay.
But I'll come back to you and pick up a conversation with the chief officer in Angus, who's has the lead partner role for primary care.
Yeah, thank you. Thank you, Beth. If I may comment on this, I just think it's important that something like this is undefined, I suppose, if there's going to be any changes. And while it may not be the major cost in terms of our overall budget, I think it is important that we understand what these outstanding type of items are and when they might be resolved, and if there's any risk associated with them, really, I suppose. Thank you.
Thanks, Sheila. It might be worth just referencing that again when we're discussing the primary care paper later on in the agenda, if you want, just to make sure it's minuted in that area. Okay, thank you. Any other points or questions that you want to ask Donna? I think it's worth noting the allocation of the balance of the 1 million to NHST side to balance the whole system. I think that's something that we want to acknowledge has been a result of discussions across the whole system. And I think it's welcomed as a good example of whole system working with the NHST side and the 3 IJBs. So on that basis, the recommendations are that we note the overall projected outturn for 22-23 based on financial performance to 31st of December 22. We note the projected COVID-19 expenditure and the update on COVID-19 reserves, and we note the allocation of funding from the Winter Resilience Reserve to NHST side to support whole system pressures. Is everybody happy to note that? Yep.
Happy.
Okay, thank you very much. Thank you, Donna. Right, we'll move on then to the key strategic performance indicator report. And I think, is that Chris is going to take us through that, or is it Jackie? Chris?
It's Chris, thanks.
Happy to crack on. Good morning. Thank you, Chair. quite a lengthy report with a couple of appendices today, so I'll try and skip through some of this and leave time for questions. So the report provides the Audit Performance Committee with an update on strategic performance and includes for the first time key performance updates in respect to community mental health and wellbeing and learning disability and autism, and those are updates in respect to the strategic delivery plans that relate to those particular care groups. The report provides an overview against the strategic performance indicators against in 2023 compared to 2021-22 and make similar comparisons in relation to those strategic indicators against our peer group of similar HSCPs and Scotland overall. It's important for the committee to remember that the data to which these strategic indicators relates comes at a very early stage. It comes ahead of official Public Health Scotland publications, and in so doing is useful from a management information perspective, but it may be incomplete and may be subject and is likely to change as additional validation exercises are undertaken. However, our practice to date really has been to bring to the Audit Performance Committee the most up-to-date available data with that bit of a health warning around about it. The alternative is that the data comes with an even greater delay than what's available at the moment. The committee will be aware that the Integration Joint Board reviewed strategic progress against community mental health and wellbeing and learning disability and autism recently, and appendices 3 and 4 to this report provide the committee with update key performance indicator reports in relation to those particular care groups, and we can have a look at those perhaps after the strategic indicators. As we go forward, it would be our intention to bring to the Audit Performance Committee a similar care group related KPI report at each meeting of the Audit Performance Committee, and the intention would be that we would bring that to the Audit Performance Committee ahead of IGB scrutiny of the strategic progress. So turning briefly to some of the indicators and just a brief commentary on those. Compared to 2021-22, our performance is mixed, with 3 indicators within the target range, 1 greater than 3% from target and 3 greater than 6% from target. Picking 1 or 2 of those out in particular, NI12 or emergency admissions, I felt that it was worthwhile drawing the committee's attention to that, and we've done some additional analysis there, and what we'd indicate is that 49% of emergency admissions occur in the over 65 age group, and so with a higher than a greater proportion of over 65s in Perth and Kinross, we might reasonably expect a larger number of emergency admissions when you compare to 47% and 44% for the peer group and Scotland overall. We've had a further look at readmissions, NI14, and what we can see is that readmissions within 7 days. The national indicator is within 28 days, so we've broken this down. So readmissions within 7 days of discharge have actually increased by 12%, whereas readmissions within 8 to 28 days have reduced by 10%. And that's although some people may be readmitted relatively quickly, and that needs to be investigated, we can see that beyond 8 days from discharge, people are increasingly able to be supported in the community. Couple more indicators and then we can wrap up. NI19, a number of delays, a number of days people age 75 plus spend in hospital, so that's effectively a delayed discharge, is increased by 45%. It should be noted, however, that follows a period when delayed discharges in Perth and Kinross were significantly lower than Scotland, and when we compared well to the peer group. In this respect, Despite the significant increase, the rate in Perth and Kinross remains below the rate overall for Scotland. And a further breakdown of the data confirms that patients over 65 are consistently discharged without delay in 96% of cases. So we do have a strong focus on delayed discharge, as you might expect, but it's important to point out that there's a high percentage of people leave hospital without any delay at all. And MSG3, the A&E attendances. So A&E attendances have increased overall by 7.12%. Within the 65 plus age group, however, they've actually declined since pre-pandemic levels by 14%. And that's a significant reduction when considering peer group has increased by 16.5%. So Perth and Kinross is down 14, peer group up by 16.5. Happy to pause there.
Thank you, Chris. Thanks for the report. I find this a particularly useful report. I think I like the graphs, etc. I think it's pretty visual. One thing I was going to ask, I've been privy to some meetings with Kevin Stewart, the Minister for Mental Wellbeing and Social Care, in the last few weeks. And one of the things that's been highlighted is there's no information, no indicators, etc. for mental health and learning disabilities. Now, I was keen to say that we did have some. I wonder if it's okay if I share these with the other IGBs and the other chairs of the IGBs. But I mean, they're in the public domain now, but I just wanted to make sure it was okay with you if I share these. I don't know, have they seen them before? Do we know? Jackie, Jackie,
I know Jackie might want to comment. I'm happy to come back, but I'll cede to Jackie.
Yeah, Jackie.
I've shared this with the programme team, in the Improvement Academy, really just to raise awareness across a range of folks. But I'm also aware, as Christopher Lamment's on the call, that we've already shared our indicators, not necessarily this report yet, because this is the first populated report that's come through, but we have shared the indicators with our colleagues across the board in order that they may wish to develop a shared data set. Chris may want to come in.
Thanks, Jackie. Yeah, so you're correct. We've actually shared these with our counterparts in Dundee and Angus have actually come back and are very keen to have a shared data set and be part of taking this forward. I think it's also worth mentioning, and Chris did highlight this, that the performance indicators that we've begun to identify, particularly around mental health, although these are the ones that we feel are the most important at this moment in time, they will probably expand and grow over time. And it falls in line with the National Quality Indicator Profile for Mental Health, which came out last April from a national perspective. So obviously we want to be on the front foot and make sure that we have specific indicators that relate into that as well. And I can certainly share that link for any members that are interested in reading that document.
Thank you, Chris. That would be helpful. Hamish, do you want to come in?
Yeah, it's just to build on what Jackie was saying. In fact, as chance would have it, we've got our second meeting that we've led with Dundee and Angus colleagues later this week. We undertook with the Care Governance Committee that we would lead a bit of work to harmonise these indicators across the three IJBs in Tayside, and credit to Chris and Chris for all the work they've done to lead that. So hopefully we'll have further discussion this week to bring some harmonisation on that.
That's great. Thank you for that feedback from everyone. As I say, it was a meeting with non-execs, and it was with the acting chair, Pat Kilpatrick in particular, who was keen about data. And I just wanted to reinforce that there was data there. It was something that we had. So it's just, if I'll share it with Pat Kilpatrick, I don't think she's got it through another source. So just to keep her involved. Okay, and if I can take the chair's prerogative, please just ask a couple of questions, Chris, first, before I open it up. You talked about this, you broke down the readmission figures to the under 7 days. Are we doing some investigation to see if people are being discharged too early, or is it something that's amiss with their sort of district nursing care at home support that people are being sent back? Is that something that we're starting to look at? Because it seems quite a lot within the 7 days. You were talking about delayed discharge, but the question it raises in my mind, are we actually delaying people too soon?
Yeah, thanks very much for the question, Chair. I don't know whether Jackie or one of our older people's colleagues may want to come in, but certainly from a data investigation perspective, it's the first opportunity we've actually had to break it down in this way. So we've become much more aware of this from a strategic perspective recently. I know that our colleagues in our older people's care group are looking at the whole older people's pathway. And we'll be closer to the detail of those individuals who may have returned to hospital sooner than would be ideal. And our intention will be to bring forward a similar KPI report to the Audit Performance Committee in respect to older people's, and perhaps there's an opportunity to explore that between now and then. But I can see Jackie's got her mic off.
Okay, Jackie, do you want to come in?
Yeah, I took my mic off, but I'm conscious also that Hamish, Evelyn's on leave today, so Hamish may wish to say something here as well, in that our whole work around delayed discharge and discharge without delay and the improvements there, which will come up later in a later report. We are beginning to look at some of these interesting pieces of data, but also perhaps some of our practices as well around planned date of discharge and whether there are any anomalies in Perth and Kinross, because we think there might be. So we're looking at that quite closely. I don't know, Hamish, if you want to say a little around that.
Yeah, we have looked at this, Beth. I think it's a fair challenge. I think it's important to realise the absolute numbers are very small, and Chris might want to confirm that. Don't actually. We have looked at this repeatedly over the last few years. But I think the numbers, the absolute numbers are very small. To draw conclusions and percentages or draw inferences is probably going to mislead us, I think. So I don't think there's a structural problem here, but it's something we're quite aware of.
Okay, thanks for that clarification. And the last thing I'd like to say before I hand open to any questions, I think the figures about the attendance at A&E, I think the work we've been doing in Perth and Kinross around the frailty team, etc., is actually coming through now. So I'd like to congratulate everybody that's been involved in that frailty work. Okay, I'll put it out. Any more questions, comments out there? Martin?
Yes, I put question in the chat box, if I may.
Oh, yep. Okay, sorry, it's just all Councillor Sheila McCall and then Martin.
Thank you, Beth. I have two questions, if I may. One is around the report itself, which I think is really helpful. And really, is it, when we're looking at the stats and the data, is it around presentation at health facilities in Perth and Kinross, or is it based on the Perth and Kinross residents' representation at health facilities across Tayside?
So this relates to population data for residents of Perth and Kinross, no matter where they present. So there'll be a small number that may have presented even in Forth Valley, for example, or in Fife, and a larger number in Nine Wells, for example. So it's the Perth and Kinross population.
Okay, right, that's interesting, because I think what would be interesting to me and perhaps other members of the board is to understand, therefore, in terms of readmittance within a certain period of time, where those readmittances occurred from, whether or not distance or location has any impact on that. So that might be something, I don't know if it's possible to do that. I know it's quite early days in starting to gather these and establish data sets. But I do know that certainly in Perth and Kinross, a large number of our population do not present to hospitals within the Perth and Kinross area, but indeed present to mostly to Dundee area. But I accept there's elsewhere, and in fact, and quite a few people present elsewhere to national treatment centres as well. So I think that might be a useful thing to understand a bit better, just when we're delving down into the data, if that's possible to get.
Yep, we can certainly have a look into any relationship that may or may not exist there. I might refer to Hamish Dougal as well on that, given the absolute numbers that we were referring to there are quite small, so percentages can change due to small numbers, but we can certainly have a look at that.
Thank you. I think particularly for older people who are frailer, you know, I think distance and et cetera often has an impact. Just and often I think people like to get home more quickly if they're further away from home. That's just a personal observation rather than any empirical evidence I have to that thing. My second question, if I may, Chair, is on Appendix 4, the Performance Management Framework in terms of autism and learning disabilities. I'd be curious to find out more about how this data is gathered and from whom in order to achieve the, because on the face of it, it looks extremely good. But I know that some of the indicators, for example, of access to support by appropriately trained workforce, I don't know what that means by appropriately trained in terms of what people's needs are. So I'm just curious to know a bit more about that, and I'm happy. I know that's quite a wide-reaching question. So if it's easier to take it offline and maybe report back at the next committee, I'd be happy to do that rather than take up a lot of time today, Beth, given your time constraints.
I think that would be helpful if we could do it offline. Jackie, you want to come in?
Yeah, I think it probably would be helpful to have a session around some of this, because what the kind of questions that you're asking are the questions that this would be leading us to, but it's our first report, so it's really just to recognise that, but also that we're very conscious that this is primarily brought forward as a result of certain surveys, and we want to actually enhance that much further by bringing forward data around the stories that are being achieved through care opinion as well, so that it's backed up by more qualitative experiential examples. So so it was really just to say, yeah, I think it would be helpful to have a session really just to have a closer look at that and to understand where the data is coming from and how we might enhance that further. Happy to do that.
Yeah, thank you, Beth. I'm happy with that, Jackie, as well.
Thank you. It might be possible, Jackie. We've got the development for the clinical governance. It's sort of extending it out to the information on this committee, so it takes in some of the performance and risk data as well. I know we're having a specific risk, but we can report that back at the development event around all the data that we're receiving and how we're using it and understand it, perhaps. Okay, Martin, and then David, are you wanting a question? I wasn't sure whether...
I think Martin's first.
Right, okay, Martin, if you want to go, and then David.
Thanks, Chair. And it's under in 3.2, the National Indicator Breakdown in NI 14 and NI 19. I want to ask questions on, and my first question has been Beth has actually asked about the 12% and the 7-day period of discharge. I would be concerned about that as well. But when we go on then to 8 to 28 days, there's a 10% reduction. So there's a correlation between the 12% and the 10% reduction, and we're catching everybody in the first 7 days because I'm having a difficulty in light for light there, and why there's that reduction and why there's that increase in the first 7 days. I would believe, and it may be anecdotal, but if people are being readmitted within 7 days, well, that needs to be looked at significantly. That's my first question. And the second is in 19, that the increase of 45% on people aged 75 plus spending in hospital. But when we go down to over 65, the 90%, 96% of cases over the same period were discharged. obviously there may be the element of illness, but what do we have problems with power of attorney or guardianship? Is that why we're keeping some people in hospital?
Okay, thank you. Chris, do you want to start trying to? I think you probably answered the first question.
In respect to readmissions, yeah, I think hopefully we have. In terms of NI 19, I'd probably need to cede to Jackie or Mr. Ogilvie in respect to guardianship issues.
Jackie, you're on. Your mic's on.
I can pick up on the guardianship issues in that we monitor this very closely, and Martin, we've had feedback from the Mental Welfare Commission about our processes being effective, and one of the reasons that I mean we're continuing to focus on this, but the numbers are actually quite low in terms of delayed discharges, but they tend to be very complex when this arises. But we've got very good relationships with our legal services in Perth and Kinross Council, where if there is a requirement to the family are unable to, or there's a difficulty associated with that, we've got very good relationships with our legal services and good and timely responses there. But I don't think is our major issue. Our major issue in terms of delayed discharges is clearly around the need for care packages and complex care packages, and the unavailability of services to meet that need. The adults with incapacity is actually quite small.
Okay, thank you. Thanks, Jackie. Okay, thank you, Martin. David, and then Sandy.
Right. Thank you, Chair. I'd like to ask about Appendix 4 and the question percentage of service users supported at home who are able to maximise their health independence and maintain their quality of life. Two questions. First of all, it sees a drop down to 74%. Is it affected by a low sample size? And given that it relates to autistic and learning disabled, do the respondents have the mental capacity to answer these questions?
Happy to take that, Chair. Thanks very much for the question, Councillor Illingworth. Yes, I mean the sample sizes are relatively small, and we've tried to acknowledge that within the report. I think I'd say a couple of general points just around the survey that's used to try and gather this information is strongly linked to the National Health and Care Experience Survey, which is undertaken every 2 years. But we recognise that every 2 years isn't frequent enough for us to understand what's going on within our individual services. And so over the past 12 months or so, we've sought to bring in an internal based survey with a similar set of questions strongly linked to the National Health and Wellbeing outcomes, so as to give us, as good as we can, an indication of what's going on between those surveys that happen every 2 years on a national basis. The one other comment I'll make in general terms is that what we do know is that the surveys that we undertake internally that populate this and other reports are in relation to people who have actually accessed their services, as opposed to the national survey, which is on a much larger sample size for people who may or may not have actually accessed their services. So there are data quality related issues for both, but just quite different data quality issues. What I would say, however, is in respect to the second part of your question about the capacity for people to answer the questions, we've gone to some significant length to create easy read versions of the survey, and the survey allows or caters for people to answer that through their carer or through a member of staff or whomever else is able to support that person. So there's not a need. It's not particularly complex, and it's not something that we would have an expectation of all service users having a capability of doing, but they could quite easily be supported to do so.
Okay, thank you, Chris. Sandy?
Thank you, Chair. My question is around the older people services. In 3.1, it talks about variations in the targets which are not particularly successful for older people service. And it talks about the recruitment and retention challenges and says that they probably impact on performance. But almost in contrast to that, we've already mentioned MSG3 and A&E attendances for 65 plus, and that is hugely successful, very significantly so. Is there any link there? Do we know, is that the frailty team, and are they particularly well staffed? And is that why they are able to perform so well, which is hugely commendable? But is there a link there? Is it a staffing issue, or are there any other indications that the data gives as to why that is working so well? And we could carry things over into other areas and help improve some of the performances. I don't know if that even makes sense.
No, it does. Yeah. Thanks for the chair. Thanks for the question, Chair. I'm happy to respond in part, and perhaps operational colleagues may want to comment as well. What I would say is it's complex, is what I would say. It is a complicated landscape, and there will be pockets across that whole older people's pathway where, to a greater or lesser extent, I'm sure there will be operational gaps in terms of that recruitment. And while I couldn't provide you at the moment with empirical evidence that service X is having effect Y, what we can say is that there is clearly some success in parts of the pathway, and particularly in relation to what you've mentioned there. But how we draw that through into a wider pathway and improving each of those other elements is a more complex and difficult conundrum, one which exercises us within the HSCP, and as I referred earlier in one of my answers, we will be bringing forward an older people's KPI report, which looks at a broader set of indicators as well as these that I think is due to come later in the year. Happy to pause there. Hopefully that answers the question in part.
Thank you.
Amy, sure, you want to comment in general, but do you want to comment on this, or do we want to put that on to Level and coming back next meeting?
I think, to summarise what Chris says, it's complex, and I think one of the things we've done in relation to monitoring the performance is we've now developed a weekly dashboard that tells us exactly, where people are being admitted, where the blockages are in the system, and also where we make changes, we'll be able to follow a little bit more exactly what impact those changes have had, although recognising that lots of things change all at once in health and social care. My comment, Beth, is really just, if I might be permitted to come back to David Illingworth's question, which was around Appendix 4 and the autism learning disabilities, and I think behind the question was the question about what we're doing to support health and well-being in that particular group. I think if I picked that up right, David, and it's just to highlight that the Scottish Government brought out directives last year, directions that all NHS boards have to carry out quite broad but yet quite holistic health checks annually in this group, and part of that will be about general lifestyle supports, health, and all the whole range of care. It's not just it's quite broad check and support in health and well-being, and that is been slightly delayed, but we're now going out, and it will be a kind of melded process with using existing learning disability services and also primary care GP practices. But what that exactly will look like, we're not quite sure, but it is a pretty comprehensive support package and intervention.
Okay, thank you. And I know I went out to visit in Murray Royal, the team that are doing a lot of the physical health checks as well. So that was a pretty impressive. Okay, any other comments? Sheila, you've come on screen. Are you wanting to?
Yeah, I have. Thank you, Beth, and thank you, Hamish, for that update. You know, I think it's very welcome that there will be these comprehensive annual health checks carried out. However, in my personal experience, I find that very often these are carried out primarily with caregivers or with, like you said, GPs or other professionals, and there isn't enough voices heard from the actual individuals themselves, particularly those with learning disabilities who quite frequently have difficulty making themselves understood or being understood, let me put it like that, rather than making themselves understood. And so I think if we are going to move this forward, which again, as I said, is very welcome, I think we need to ensure that we're as comprehensive as we can and speak more directly to the individuals with learning disabilities and autism, and indeed perhaps their immediate peer group outside of their care providers, and as well, I'm not saying we should exclude them, but we should the care providers and the professionals, because I think they have valuable insight and a perspective that's really, really useful. But I think that if we really want to be serious about this, I think we really need to widen our scope to include the wider society in which all of these people live.
Thank you for that, Sheila. Thanks for your comment. I know Jackie's noted that, and I think that's noticed in the Mental Health and Learning Disability Action Plan that we might touch on. Are you want to come in now, Jackie, or will we want to move on?
Yeah, I was just going to say very briefly that there's a piece of work underway at the moment, which is redesigning day opportunities for people with learning disabilities, and that's a piece of work that's been led by Moira Gill, who's got specific interest in co-production and redesign. I went along to one of the sessions. There's more sessions coming up in the next few weeks, and it's been identified nationally as something of interest to Jason Leach, and he's going to be coming to Perth on the 23rd of March. There's possibly an opportunity here to be in alignment with that work, to be rethinking how we engage with people with learning disabilities around how they may wish to report what quality indicators are important to them, because this was very much a focus on living a good life. So there's a potential to do some work on the back of that initiative to further enhance what we have here today. And just as a reminder that this is the first report that we've brought forward in this area, and recognising that there's still some way to go with that, particularly around not just the indicators, but also in terms of the presentation, so that it's understood by the people who are receiving those services. So a wee bit of work to do, I think. Thanks. So thanks for that, because I entirely agree with you.
Okay, thanks for that. And the last question I think we'll take is David Illingworth.
Hello. Hi. Thanks, Sheila. Sorry, Beth. Is it possible to have an N number of sample size in the graphs? It gives us some idea of how significant these issues are.
Yeah, we can look to include that as we move forward.
Thank you. Thanks for that.
Thank you.
Okay, I think we've had a jolly good debate on that. Sorry, no pun intended, Chris. So our recommendations are that we note the Health and Social Care Partnership's performance to date against key integration indicators, and we note the progress made in respect to the delivery of strategic delivery plan outcomes. Are we happy to note those? Yeah. Okay, thank you for that. That was a very useful debate. We'll move on now to governance and assurance, and the next item is a strategic risk management update. Is that yourself, Jackie, that's taking this forward, or is there someone doing it on your behalf?
I'm happy to introduce the report.
Okay, thank you.
Chair, and Chris Jolly's also in the meeting, so able to support any questions that might arise from this. This report is coming forward to give an update on the strategic risk register and update on our progress in terms of improvement actions and our controls, and also to update on new emerging risks and material changes. The strategic risk register has a strategic risk improvement plan, and the Perth and Kinross Health and Social Care Partnership Executive Management Team routinely considers these strategic risks and to make a collective and balanced assessment of those risks, and this report identifies a number of changes that have occurred since the last report to the IGB. You'll see that under strategic risk number 09 around the leadership team, that was originally around capacity within the leadership team, and we've amended that and updated that because there are no gaps in the Health and Social Care Partnership leadership team with all posts recruited to and in place. However, we're recognising that 2 of those posts, that's 2 whole-time equivalent, are filled on an interim basis, and there's a need to establish a new and permanent integrated senior management structure to ensure stability in the leadership team. And so there's a slight change there in terms of what the risk actually is. And SR10 in corporate support, we have archived that risk as a strategic risk and included those elements which are now incorporated into the workforce risk SR02. And SR14 is around partnership premises, the likelihood of that risk, and the scoring has increased, and that's because of some of the discussions that have been taking place with our partners, both at NHS and the council primarily, around a reduction in office and corporate buildings, and that may mean that some of our answers to our long-term premises issues may change, so we've increased the risks around that. And the report also gives the detail in relation to the justification around the risk scoring, and also sets out, as we were saying when we started the meeting around the action plan, the risk appetite development session will take place on Wednesday of this week, and thereafter we will produce a risk appetite statement to be brought forward to the IGB for approval on the 21st of June. So overall, our position remains relatively steady, with the exception of the increase in risk exposure to the partnership premises strategic risk. So, and Chris and I am happy to pick up any questions, and there's others from the executive management team in terms of some of the specifics as well. Thank you.
Thank you, Jackie, for that. My question is really around primary care. I know that we've got it as a 16 in Perth and Kinross, and I know that the report, the audit report which is on the agenda, was very much around the work that we've been doing in Perth and Kinross around our sustainability work. But I was just wondering, bearing in mind that across the Tayside it's now a 25 high risk, and in light of Invergowrie and other issues, is it still something that we consider to just be a 16? I don't know if Hamish wants to come in on that.
I'm sure Hamish will want to comment on that. One of the issues with these papers is that in terms of the preparation and the review of the strategic risk, there is a bit of a lag. So there are things moving in a number of these risks, and primary care will be one of those, where I think when the risks were reviewed here, the notification in relation to Invergowrie had not yet been factored in, but I'll let Hamish come in with an overview on that one.
Thank you, Hamish.
No, I'd agree. I think there is a lag in those timescales, and sorry, somebody at my door. I'm at work. It could be, we could revise it. I think I think when we come on to the sustainability paper, given that it's currently a hosted service or a lead partner agency, there's some perhaps need or requirement to harmonise the risk across the expression of that risk, and there's been work going on led by Angus. Although I think the risks are different in each of the 3 areas. And I think probably 16 was a fair risk at the time of writing of the report, but now we've got Invergowrie, which remains to be seen how that will pan out over the next few months. So I think it's reasonable we go back and look at it again.
Okay.
I'm not hearing that there are other pressures in the system as well in terms of practices, turnover, losing staff. So it is probably something we should be reviewing.
Okay, thank you for that. Any other questions? Any other comments? No. I think we'll be covering this in a bit more detail on Wednesday, but today we're asked to approve the IGB Strategic Risk Register and Strategic Risk Improvement Plan, and to note the current position of the IGB Strategic Risk Exposure Scores as at Section 3. I think it's also noted that we're going to have another look at the primary care risk. Is everyone happy with that? Okay,
Happy.
Thank you very much. We'll move on to the Partnership Improvement Plan update. Jackie, are you taking us through this, or is somebody taking us through it on your behalf?
I don't know. I'm not sure if Phil's here. If Phil wants to come in on this one.
Yeah, I could do that.
Thank you.
Thank you, Phil.
Hi, thank you very much. The progress against the actions within our Partnership Improvement Plan presented today to the committee for noting. So since the last time the plan came to the Audit Performance Committee, we identified 5 potential new actions that were considered for inclusion in the plan today. These actions have arisen from the completion of a couple of audits, the internal audit concerning corporate support and the annual external audit. 5 actions were identified from that. Both of these audit reports were considered by this committee previously. Of these potential 5 new actions, 1 has been incorporated into an existing action and the other 4 are now new actions, and they're detailed on table 1 of today's report. Just to point out, in case anybody noticed, there's a typo in section 3.3 where it says 5 of the improvement actions are at a red RAG status. That should say 2, which you'll see from the table 2 below. These 2 actions which are red are due to the original target date being surpassed, but the actions are ongoing and we would expect them to move from a red status and by the next report. So overall in the report we can see that we continue to make progress in the improvement plan with several actions now moving on to complete status, and the report details that overall 59% of all the actions that we've had are now considered to be complete, and that compares favourably to 54%, which was in the last report which came to committee. So just to conclude, the committee are asked to note the progress in the plan. The plan as detailed at Appendix 1 of the report, and the next time this Partnership Improvement Plan comes to the committee in September this year, we will have considered the annual review of governance and the annual governance statement, and we would be expecting some completed audit assignments, so there's likely to be significant further actions on the Partnership Improvement Plan. Hand over for any questions. Thank you.
Thank you, Phil. I think it's a pretty comprehensive report, and the good thing about it is there's no surprises for me, so I think that it's all seems to be going well, but I'll open it up for any further questions or comments. Anyone got any questions for Phil or any comments on the... No, Okay, good stuff. So as Phil said, the recommendation is we note the progress towards achievement of actions within the Partnership Improvement Plan. Are we all happy with that? Okay.
Happy.
Thank you very much. Next item is the internal audit progress report. Jackie, is that yourself? Yep.
Yes,
Thank you.
thank you, Chair. This report presents the progress that has been made against internal audit plans for the IJB. The Primary Care Improvement Plan final report is included later on this agenda. Planning has commenced for all the assignments from the 22-23 plans, and scoping will be agreed shortly with the partnership, where this is yet to be shared. I anticipate that that the outcomes from these assignments will all be complete in time for inclusion within my annual report, which will be provided to the next meeting of the Audit and Performance Committee. I'm happy to take any questions if there are any, if there's anything particular on this.
Any questions that anybody wants to raise? The only thing that I was going to ask Jackie, are we still confident we're on plan to report in June of this year?
Yes, I would. I certainly anticipate at this point that shouldn't be an issue. That the outcomes should be available for June.
That's great. Thank you. Okay, if there are no further questions, we'll move on to the next.
Oh, I have a quick question.
Sorry, David. Sorry, I never noticed.
In the progress, I know I should know the answer to this, but progress report March 2023, at the end there's a column for grade. What does grade mean?
That is for when the outcome or the report has been finalised, and it will say whether or not the reasonable reliance can be placed, or limited reliance, or so on, in line with what is recorded within the audit report.
Great, thank you.
Thank you very much. Right, we'll move on then to the actual audit report feedback, and it's the internal audit report, sustainability of primary care. Jackie, you want to take us through our comment, please?
Yeah, thank you, Chair. The sustainability of primary care final report is before you today, and the committee will recall that this was provided before as a draft final at a previous meeting, and it was presented as a draft final due to the complications and the complexities in agreeing the final actions because of its wide reach across all IJBs within Tayside. The actions have now been agreed with a greater level of detail recorded and captured within the agreed actions, and hence this is being brought back to this committee. These actions are being led by the Chief Officer for Angus. What was included within the internal audit plan for the Perth and Kinross Integration Joint Board was a review around the primary care improvement plan. And I would again draw the committee's attention to the fact that reasonable assurance can be placed in the arrangements in this regard. And the commentary on this section hasn't changed since since it was previously presented here. I'd also draw your attention to the fact that within the detailed findings section 3, which is on page 127 of this pack, that there are some areas highlighted which were noted as areas of good practice. I'm happy to take any questions at this point, but I really would say that this is the final report and that has already been subject to the Audit and Performance Committee review at a previous meeting.
Okay, thank you for that, Jackie. I know there was a bit of confusion about issues and timeframes, but everybody's got this final report now, so thank you for that. I am happy to put it out for any questions or comments. Nope, we're happy. The one question that I wanted to make sure is the work that's been recommended. Are we happy that we're engaged? Because we're not, obviously it's hosted by Angus. I just wanted to make sure that from a Perth and Kinross perspective, we feel engaged and part of the process of moving this forward. Hamish, I think I asked that at the last meeting and you weren't quite 100% convinced. I just wanted reassurance that we now feel engaged in the process, particularly the development of the primary care board.
Yeah, I think we're active in the discussions on that. I think the issues around shared risk in terms of finance, etc., are probably more strategic and need to happen at a less operational level.
Yeah, it was just to make sure that you felt comfortable that we were engaged and involved. And, you know, I would commend Perth and Kinross work, particularly within the sustainability work that was highlighted as good practice. So thank you for that and well done. Okay, if that's no further comments, the committee is asked to note the contents of the final report for the wider review of the strategic risk relating to primary care, which incorporates a review of Perth and Kinross primary care improvement plan. Okay. So the next item we'll move on to is the annual audit plan. And I think that's yourself, Donna.
Thank you, Chair. We'd like to pass to Maggie Bruce at Audit Scotland, if I can. Thank you.
Welcome, Maggie, to the meeting.
Thank you, Chair. I am the Senior Audit Manager who is responsible for delivery of the IJB external audit. It will.
Oh, you've gone on to mute, Maggie. That's it,
Sorry.
You're back. That's
Sorry,
okay.
Can you hear me now?
Yes.
Not sure what happened there. So I was just explaining that I'm the Senior Audit Manager for the audit of the IJB, and it will be my colleague Brian Howarth, who is unfortunately in other meetings today, who will actually be signing the accounts in due course. But I'm going to take you through the annual audit plan for the 22-23 audit. So before I get into the detail of the plan, if I could maybe draw members' attention to paragraph 11 in the plan, which is asking yourselves as those charged with governance to provide me with confirmation that you're not aware of any actual suspected or alleged fraud. This is a requirement of the standards on auditing, so we're required to ask those charged with governance. So if I could ask that perhaps at the end of this section I could be provided with a positive assurance that you're not aware of anything that needs to be brought to our attention and therefore included in our approach to the audit. Thank you very much. So the financial statements audit planning section of the report sets out our materiality levels for our audit of the financial statements. And at Exhibit 2, the risks we have identified that we need to consider as part of our audit of the financial statements. And in Exhibit 2, we set out the risk, we set out the source of assurance from officers, and we also set out what we plan to do in response to those risks. So the first risk, the management override of control, is a risk that all external auditors have to consider in all financial statements. So it isn't specifically aimed at Perth and Kinross IJB. And the second risk, I think, has already been referenced in earlier papers about the return of the COVID-19 reserves. And because this is something quite unusual, we've identified there the risk as much as to how that's going to be accounted for through the financial statement, and also making sure that it's consistent with the accounting treatment in both NHS Trayside and Perth and Kinross accounts. In paragraphs 18 and 19, we're also required to consider specific risks associated with income and expenditure transactions, but due to the nature of the IJB, we have rebutted these and therefore we won't be doing any additional work in association with these. We've referenced the additional work that's required under the revised ISA 315 on understanding the IT systems and the controls and operation within them, and also our requirement to comment specifically on the management commentary the annual governance statement and the audited part of the remuneration report. On paragraph 9 of our plan, we set out the work that we're going to be doing in connection with the wider scope of public sector audit and the best value arrangements. The plan also sets out our timetable for the audit. In Exhibit 3, we set out when we're proposing to provide the key outputs from the audit by, and at Exhibit 4, the timetable for completion of the audit. COVID-19 continues to have a legacy impact on the timing of our audits, and we're working towards the 31st of October 2023 date for completion of the audit. We also set out the audit fee there, but I note that there's a separate paper on that, so I'll leave any comment on that until then. Final thing is just to note that we will not be placing any particular formal reliance on internal audits work, but we read all of the reports and consider the impact for our approach. Finally, at the appendix, a little bit of background about Brian Howarth, myself and Mary O'Connor, who is the senior auditor who will be dealing with the day-to-day work on the IJB audit. Thank you very much, Chair.
Thank you, Maggie. Firstly, I would like to reassure on behalf of myself and the committee, and I think I speak for everybody, that we're not aware of anything that could be considered as fraud or any areas in that area. Yep. Councillor David Illingworth, you have got a question.
I have a question too, Ben.
I suspect Sheila's before me, but if you don't mind, I'll just go.
Yep.
Maggie, do you think this is the first time at Audit Scotland have done IJB, and it was previous KPMG. What will be the differences, you think, between your approach and KPMG's approach, if any?
I find this quite a difficult. I've had this question before, actually. I find it quite difficult because I've never worked for KPMG. I mean, I think what I would assure members is we're all working towards the same standards. You know, there are very strict standards set down for external auditors, so we're all working towards the same standards, and we're also required to follow the Code of Audit Practice 2021. I wouldn't imagine that the approach would be too different, to be honest, but I can't say definitively because I don't know what KPMG's approach was.
Okay.
Thank you.
Sheila.
Thank you. I have a wry smile there at David's question. In my lifetime, I have purchased audit services from a whole variety of organisations, and I usually find, in fact, that the specification of the purchaser is what prevails, rather than the methodology necessarily of the provider. So hopefully, David, that may give you some reassurance, but it'll be interesting to see. I have worked with Audit Scotland, KPMG and a variety of others in the past, so I think it's really up to us as an IJB, I think, to be clear about what we expect from the services that are being provided. But that's not my question. Maggie, thank you for that report. My question really is around fraud. I also sit in the Audit and Risk Committee of the NHS Tayside Board, and they too would consider items of fraud as part of their remit. And so my question really is, if something's brought forward there in terms of a healthcare setting, not that I'm aware of anything, otherwise I would declare it. But I'm just curious as to how that possible overlap, it's not a conflict, but an overlap might be managed, and how you would work with the auditors, who it could indeed be yourselves, of NHS Tayside. But I know there's separations of duties when you're auditing different organisations, so I'm curious to how that would be managed. Thank you.
Yes, thank you. Can you hear me? I'm getting an unmute. Hello, can you hear me?
We can hear you,
yeah.
Okay, thank you. So yeah, I think that's a good question. So as part of our audit of the IJB, we would write to the host partners for assurance. So I personally am involved in the audit of Perth and Kinross Council, so obviously I have a very detailed knowledge of what's going on in Perth and Kinross Council, but I am still required as part of our approach to write to, not myself, but to my colleague Brian Howarth, to give him an assurance on the situation from Perth and Kinross Council. I am not involved in the audit of NHS side, but within Brian is the appointed auditor for NHS side. So my equivalent in the NHS side audit will also write to Brian to give him assurances from that audit. So we have quite a formal approach in place to make sure that we're getting the assurances we need for the IJB audit. And we also have the informal situation of all working for Brian and being part and parcel of manager meetings, etc., where any issues or concerns would be discussed.
Okay, thank you. I'll be interested to see how that evolves, since I have a foot in both camps, not Perth and Kinross Council, oddly, even though I'm a Perth and Kinross Council, but within the Health Board and the IJB. So I'll be curious to see how that progresses. Thank you, Maggie.
Okay, thank you, Sheila. Any other points of clarification? Oh, Martin, sorry, I see you've got a point, a question.
Yes, I worked with the Audit Scotland in a previous role in Fife. I'm just asking on the target dates. Are the target dates well within capability of being reached, and there'll be no breaches of the target dates?
As things currently stand, we are reasonably confident that the target dates are within reach. There are some resourcing issues within our audit services group, which is a larger grouping than what I work within. But as things currently stand, we do have sufficient resources to meet the target date of the 31st of October.
Thank you for that assurance, Maggie. Okay, if there's no other points, I will acknowledge receipt of the plan. Thank you very much, Maggie, for taking us through that. And we'll move on to the next item, as Maggie alluded to, the external audit fee for 22-23. And that is Donna. Donna, could we?
Yep, thank you, Chair. So each year we bring a report with the external audit fee proposed for that year's audit. So that's what this report is to do, is to ask for approval for the fee that's been proposed for this year's audit. The paper does, however, note that there has been an increase in the base fee, which is a higher percentage than we would normally have seen. However, Audit Scotland have provided an explanation as to why that base fee has been increased to the level detailed. However, due to the change in auditors this year, we don't have an additional fee that was normally charged by KPMG, and we also have some rebate from a previous year. Therefore, although the base fee has been increased, the overall cost of the audit, or proposed cost of the audit, is actually a small decrease on what we paid last year. So therefore, I would ask the committee to note the explanation for the increase in the base fee, but also to approve the proposed fee. Thank you.
Thank you, Donna. Any questions or comments? Sheila?
Hi, thank you, Beth, and thank you, Donna. I note there's a rebate from prior years, but that doesn't really take away from the 12.6% increase in the base fee, which presumably would then be the base for next year. And so I'm not 100% happy with that amount of an increase, given that even today there's no travel required, there's no there for subsistence when people are able to attend remotely. I know you can't do that for everything from an audit perspective, but I am a little bit concerned that it's costing more than expected because we won't have the rebate from prior years to make the figures look better. So I would like some assurance from either from our CFO or from our interim CFO, sorry, or Audit Scotland, as to what the projected increases are going forward, because you know, in section 2.4, you're saying the scope of the audit, regular and industry requirements have increased, but I can't imagine they would have increased suddenly overnight. They must have been forecasted. So I'm just a little bit concerned that there's been quite a big increase, and would like some assurances going forward that we will have a better handle on it and we won't necessarily be subject to another 12.6% increase in following years. Thank you.
Donna, do you want to take that and then maybe hand over to Maggie?
Yes, thank you. Your thoughts have been shared, have been replicated nationally, Councillor McCall, and we as a CFO section did send a letter to Audit Scotland to highlight our concerns over the increase in the rate, and we were provided with a letter detailing the explanation. Therefore, any further increase on this that would be above what would be regarded as a normal increase would certainly be raised by the section, and we can give you that assurance that we wouldn't just accept that. We would ask for more explanation as to why it would be increased above a normal level. But Maggie, I'm not sure if this is your remit, but I'll bring you in if you can.
Yes, the setting of fees is a separate department within Audit Scotland. We're advised what the expected level is, what we call it. It's the lowest level. We're then able to negotiate additional fee over and above that if we think there are additional risks, etc., that would lead to more work. Our assessment this year is that that is not the case, so we have set the fee at the expected level, but the actual setting of the expected level, the base, as it's described in this paper, is not within my gift. We are told what the minimum cost is to deliver the audit on the basis of the time that is taken over the the previous years, etc. And I have absolutely no insight into what increases or not might take place in the future.
Okay,
Thank
thanks
you.
for that, Maggie.
Can
I
I-
appreciate yours, please.
Can I just make one other kind of comment back? I mean, in section 2.1, it said it's based on the Audit Scotland's funding and fee strategy, and the two key principles is that audit fees should be set with the objective to recover the full cost of the audit, and the cost of the audit should be independent of the identity or location of the auditor. But that and from past experience, I have to confess, these are contradictory statements, because very often recovering the full cost is very much dependent upon the identity of the auditor, many of whom attract different fee rates and different costs depending on their seniority, etc. So I think that 2.1 for me anyway, like I said, based on past experience, is a concern because one cancels out the other, in other words. Donna, I'm quite happy to have a separate chat with you about that. I know I brought it up at some of our financial discussions before, but I just think it's something that requires a little bit of clarity, and it's maybe just the way it's worded there just now.
Yep, certainly, we'll do that.
Thank you, Beth. Thanks, everyone.
No, thank you, Sheila, for sharing your experience with us. And I think Donna has highlighted the amount of work that has gone on to try and clarify this and the contact with Audit Scotland. So we're asked to note Audit Scotland's explanation for the increase in the base fee and to approve the proposed external audit fee for 2023. Can we note that, please? And approve the expenses. Okay.
Happy.
Thank you. Okay, then that's the audit finished, and we'll move on to clinical care governance and the clinical care governance assurance arrangements. We've got the paper there. It says report by the Chief Officer. Jackie, are you taking us through this, or is it Hamish or Kenny?
I'm happy to come in there.
Yeah, that's fine.
Thanks, Kenny.
Okay, the purpose of this report is to provide assurance to the Audit and Performance Committee in respect of clinical care and professional governance arrangements in place for delegated and lead partner services managed by Perth and Kinross Health and Social Care Partnership. The Care and Professional Governance Forum, of which I am co-chair along with Hamish, That continues to meet monthly, and together with locality care governance arrangements provides assurance on the quality, safety and effectiveness of all services delegated to the IJB. The Care and Professional Governance Forum reports to NHS Tayside's Care Governance Committee with regular assurance and exception reports, and we are currently awaiting confirmation of a start date for a similar process in reporting to Perth and Kinross Council's Scrutiny and Performance Committee. And the Chief Officer confirms effectiveness of the systems in place within the partnership and with partner organisations. And you'll see included in the report extracts from the minutes to the Care Governance Committee on the 6th of October of last year, and also the assurance report which was presented on the 1st of December last year. Just a very brief summary, those appendices discuss the pharmacy IT system in the prisons, and this is a national issue, and as yet it's unresolved. Currently the biggest impact is on staff time of prison healthcare rather than any direct impact on people in the prison. And there were 3 red risks highlighted: accommodation, which we've already discussed in terms of the strategic risks. Just operationally, in terms of Drumhar, improvement work has started there, which will enhance the ability of our integrated substance use service to deliver. Also, the mental health workforce, and again, there is a whole system redesign taking place, looking at trying to enhance the role of advanced nurse practitioners to try and mitigate the impact of the ongoing challenge in recruiting consultants. And the access team staffing levels, that's our adult social work intake team, that was at red. However, if you look at the appendix, there's talk about a new model being introduced. That has now been introduced, and that situation has improved significantly. So I'm happy to take any questions.
Okay, thank you. It might be worth noting that I'm taking over as chair of the NHS Tayside Care Governance Group as from the 1st of April. And all of this, and I hope my experience Sorry about that, I get kicked out there for a moment. Can you hear me again? Yeah, so I suppose we were looking at, was the information sufficient to give this committee assurance? And I think the extract and the report, copy of the report to Care Governance Committee is useful. I would just be questioning whether we could have an exception report, just a short, if there are any exceptions that this committee would need to note subsequent to the previous report, bearing in mind there was a sort of time delay. I don't want another report. That information I think is sufficient, but it would be useful to have just any exception report if there is anything that is veered from the report to the Major Care Governance Committee. And the only other question from me, it's kind of technical question, it might be Hamish that can answer this. In the categories we look at the clinical challenging behaviour, I'm not sure what clinical challenging behaviour is apart from violence and aggression. It's before that, and then it's clinically challenging. Can you tell me what clinically challenging behaviour is? If that's possible. Is Hamish around? Nope. I think Hamish must have been called away. Oh, there's Hamish now. Sorry,
no,
Hamish.
Apologies, I got booted off just as Kenny finished speaking, so I have no idea what the question is and if it's correct.
Sorry, Hamish.
I do apologise.
No, I was just summarising that I'm happy that we don't do other big reports, and the report to the Clinical Care Governance Committee is probably sufficient, but I would think that we could maybe do a brief exception report for this committee, and it's covering the time frame between the difference. But the question that I had was within the report, they talked about violence and aggression and then clinically challenging behaviour, and I was just wanting some clarity on what the difference is, what clinical challenging behaviour actually is.
Chris Lamont's still on the call. Chris, you're probably more operationally involved with this than I am. I don't know how they differentiate by definition, actually.
Thanks,
Yeah.
Chris.
Can everybody hear me? Because I got kicked
Yeah.
out as well. It must be a Teams thing. So basically, the nuts and bolts of it is, if you're talking about clinically challenging behaviour, you're usually referring to things like individuals under the influence of substances, or an environment that isn't particularly suitable for seeing individuals from a clinical perspective, i.e. Drumheart, or various situations like that.
Okay, thank you for that clarity. It was just to make sense for me. Any other question? Sorry, Kamish.
I know there was a lot. I know there's a lot of discussion. Just going back to the comment about us producing a separate exception report, but I just wonder, there's a lot of conversation went on about the whole process of how it gets to the APC, and that the APC's role is to seek assurances at NHS Tayside is undertaking that. So if we produce a separate report, that report wouldn't be going to the Care Governance Committee, so you wouldn't be able to take an assurance that the Care Governance Committee had received that report. But that's maybe all procedural.
Well, that's something I think we can cover in the development event, but I think that's useful. Martin, you want to come in?
Partly answered, because I would presume that this report comes to the IGB after having been scrutinised and having gone to the clinical and care governance in NHS Tayside. So does it come to us for information? But because if it's previously been scrutinised in two arenas, I would presume it only comes to us for information. I'm kind of confused with the procedure.
I don't know if anybody else wants to clarify the procedure, but I would assume this is coming for noting. Our recommendations is that we are noting these, Martin.
Yeah, not to be rehashed in any way.
No. Okay. Any other questions? Okay. So our recommendation is that we note the responsibilities of Perth and Kinross Integration Joint Board in respect of clinical care and professional governance, and those of the IGB's partners. Note the arrangements in place for providing the IGB with assurance that effective and robust systems of clinical care and professional governance are in place, and to note that the Chief Officer confirms the effectiveness of the above systems in place in the IGB's partner organisations. Okay, is everybody happy with that?
Yep, happy.
Okay, so we're moving on then for the information section only. So we've got the work plan for 22-23, which is closing off this year. Any thoughts or comments that we want to make on that? Nope. Okay. We'll then move on to the work plan for the future year 23-24. And I think that's really just for acknowledgement. Are we all happy with that? Okay. We'll move on to the record of attendance. If people could just check that that's an accurate reflection of their attendance. Okay. We'll move on to private discussion. Is there anybody that feels there's a need for private discussion after this meeting with the auditors, both internal and external? No? Quite happy? Okay. That just leaves me to move on to the date of the next meeting, which is Monday the 26th of June at 9:30 AM. And I thank people for moving the meeting forward to 9 o'clock to enable me to get away for 11. It's much appreciated. So that just leaves me to thank you all for your attendance, and I look forward to seeing most of you on Wednesday when we're going through some of the risk issues. Jackie, is that a hybrid meeting, or are we having something in the chambers? Or
we have booked a room for it, so we'll just confirm that. But hybrid facilities will be available. Is that correct, Chris?
Yeah, we've actually written out asking for IGB members to confirm whether they will be in attendance physically or virtually. It would be of great assistance to us to know who's going to be there and who's not going to be there, because there'll be some group discussions and to help us try and manage things on the day. If members were able to indicate that. I think Val sent out a message last week, so I appreciate your assistance with that. Thank you, as well as your comment earlier, Chair, about returning the template. I appreciate that. Thank you.
Chris, would it be helpful if people were present, if they could be?
That's a difficult one. We've actually
right, I'll
got
not
two
put you in the
different.
spot. I'll just leave
Yeah.
it for people to decide. I just wondered if
Yeah.
when you're group working, if you would prefer us to be in, or
I think actually a blend might actually work okay. The worry would be that everybody would be there or everybody would be online.
Right. Okay.
We've got a couple of rooms booked, actually, one for the main meeting and a breakout room. And if we've got some more people that can be corralled into a virtual meeting room for a discussion, then that'll work as well. So hopefully it'll be okay. You might need to just bear with us a little bit as we get settled down. That's
grand. So I would encourage everybody to give a response as to attendance. Okay, well, can I thank you again for your patience and your ability to work with me to change the timings today. So thank you very much, and I'll see you on Wednesday.